Up next in this science session, which we'll follow up, we'll present on a landscape of pivotal new and emerging long COVID research. When this session is over, you'll be able to better understand the breadth of long COVID research, including epidemiology, mechanisms and pathogenesis, treatments and interventions, disability, and rehabilitation, and better understand research gaps and emerging priorities in long COVID research. Let's bring out our presenter, Trustee Long COVID Support and Visiting Professor, London South Bank University in the UK, Dr. Elaine Maxwell. Dr. Maxwell?
Thank you very much. So I'm just going to share my screen. I'm just going to do a brief introduction to some of the things we're going to talk about with the rest of the panel. And I've got all these screens, so I can't. Oh, here we go. So I'm going to just talk about some of the broad overview of the research landscape in long COVID. And I've subtitled this A Challenge for Science, because I think it really is a challenge. The sheer scale of people suffering from post-COVID-19 symptoms or long COVID has brought attention to a significantly under-researched area, that of post-viral sequelae. And I think that we can look at the research that's taken place and put it into three broad categories with varying degrees of success so far. So the first thing is describing and counting both the symptoms and the number of people with long COVID. So early in the pandemic, research focused on describing and quantifying this post-COVID sequelae. Both academics and people with lived experience were conducting surveys that described the number, very wide range, a number of symptoms associated with COVID-19 infection. But the problem then and now remains that there's uncertainty about the precise inclusion and exclusion criteria for any post-COVID diagnosis. And indeed, people with lived experience coined the term long COVID precisely to recognise this lack of boundaries. If we take the UK's National Institute for Care and Excellence, or NICE definition of long COVID, it's symptoms that continue for more than 12 weeks and not explained by an alternative diagnosis. However, that may exclude new diagnoses from diabetes to hypertension and other cardiovascular events, as well as kidney disease and the expected chronic lung pathologies, which have been demonstrated by researchers using big data to be significantly associated with COVID-19 infection. Now, I know David described that as not long COVID, but I think sometimes they could be causing the symptoms of long COVID, and we have to be careful about separating them out. These and other differences in the definition of long COVID have led to wildly different estimates of prevalence, although 2.5 years in, consensus is coalescing internationally around 10 to 30% of all people who have a COVID infection, but it does depend on your definition and your inclusion criteria. Early concerns from skeptics were that there were no controls in these surveys, but that's been increasingly addressed. So, for example, the UK Biobank study, which showed changes in the brains of people scanned pre-pandemic and after a COVID infection. There's been a recent Dutch study that tracked 23 symptoms in a cohort of people from March 2020 onwards, and that showed a residual 13% of people infected with COVID had symptoms for more than 3 months compared with controls. It's important to note, though, those 23 symptoms didn't include neurological symptoms such as brain fog, exemplifying the problem we have around the lack of a clear definition. Within the wide range of symptoms, some researchers have observed discrete clusters or phenotypes. So a recent CDC study of medical records of nearly 10,000 people with an ICD-10 post-COVID diagnosis looked at their symptoms, their investigations, and their medications, and they identified 3 clusters, one around cardiopulmonary, one neurological, and one metabolic. And that is pretty similar to a paper published by NHS England last year. What is not clear is whether different phenotypes have different causal mechanisms and need different treatments. And if that is true, it may explain why so many studies are inconclusive. And it's important to note that while post-COVID symptoms are less prevalent in children and young people, the risks are not insignificant. And a recent CDC report showed increased hazard ratios for children for a range of cardiopulmonary events, renal failure, and type 1 diabetes, as well as the other long COVID symptoms. So I think we've done a lot to describe long COVID, to look at its prevalence. I think the second area is looking at the causal mechanisms, and that is less extensive than the first, but still making headway. However, the heterogeneity of experience makes research into causal mechanisms challenging. Long COVID, as others have said, is an umbrella term for multi-system symptoms that are often episodic with periods of remission and relapse. What I see, looking at the literature, is individual researchers have explored a range of pathologies, from lung function to clotting disorders, viral persistence, mitochondrial dysfunction, dysautonomia, immune and endocrine responses, and neurological and psychological consequences. However, there's much less work looking at the interrelationships between these different pathologies. There is emerging evidence on biomarkers, and David's just talked about the work from his team, but it is too early to make definitive statements on causation. So David's recent study found levels of cortisol were lower in people with long COVID than matched controls, and that this wasn't matched by a rise in adrenocorticotropic hormone, perhaps suggesting the problem lies in the brain rather than the adrenal glands. However, as David himself has acknowledged, this study is a small sample, and as yet there's no single biomarker of long COVID that's been demonstrated in a large enough sample to cover all phenotypes. I think it's interesting to note that many findings come from single centres and have yet to be replicated by other centres to test the reliability. So there are a number of promising and plausible propositions, but there is yet unproven about the causes and therefore potential cures of long COVID, and we need to keep an open mind. There are similarities to other conditions, but there are also differences. And as David tweeted recently, anyone who tells you that they for sure know what's going on in long COVID is probably trying to sell you something. So the third area of research, and the one that I think we've done less on and we need to focus on, is managing and treating symptoms and disability. So whilst we have all this uncertainty about causation and definitions, millions of people worldwide are seeking immediate help. I think the lack of discrete definitions of long COVID and its phenotypes has made clinical trials for potential treatments more difficult and challenging. Certainly, there have been some pilots of drugs that have been disappointing, and that appears to have reduced the enthusiasm of big pharma to invest in this area. Without more robust evidence on the causal mechanisms, designing RCTs is going to be challenging. And we're seeing case studies being reported as though they were definitive, and that has led some patients to request some therapies that are as yet unproven. There are some studies looking at repurposing existing medications. So in the UK, we have the HEAL COVID study and Stimulate ICP, but they're yet to report their findings on the use of anticoagulants and anti-inflammatories to either prevent long COVID in people who've been in hospital or treat long COVID once it's established. However, this doesn't mean that there are no options. The symptoms of long COVID are frequently seen in other conditions, and there's an extensive evidence base of interventions to draw on. I know David said we need to look at pharmaceutical treatments and move away from symptom management, but certainly what I'm seeing in England is that a lot of practitioners don't understand the symptom management. So breathlessness and fatigue is common in many long-term conditions. Brain fog is seen and managed in multiple sclerosis, stroke, and cancer survivorship. Pain is a very common symptom in long COVID, and evidence on the management of many types of chronic pain is well established. So healthcare practitioners are already using transferable knowledge with people with long COVID on a daily basis, but there is little evaluation research taking place to understand which strategies work and for whom. UK Office of National Statistics reported at the end of July 2022, 1.5 million people in the UK had their day-to-day activities limited to some extent by long COVID. But there's a gap in the evidence on what form this takes, the impact of the episodic nature of long COVID on disability, and whether it presents a particular unique challenge for rehabilitation, including return to work. So we have had a number of successes. There are reasons to be positive, but there are still gaps in the research. So the associations between a COVID infection and over 200 different symptoms, plus the work on hazard ratios for new diagnosis, have been well established in multiple studies across the world, and I don't think there's any reason to doubt that anymore. Surveillance studies, including the long-running UK's ONS Prevalence of Ongoing Symptoms Survey and the more recent CDC Household Pulse surveys, track self-reported symptoms along with demographic data. The ONS data can be mapped to waves of infection in the UK and has identified a declining recovery rate as the symptom duration increases. There's also increasing evidence of different clusters of symptoms, which may help in the testing of the wide range of plausible propositions on causation that we already have. Where we have gaps, I think we do have gaps of evidence in symptom management. Working with long COVID support and with health practitioners in the UK, there is a lot that we already know that is not getting into practice. We do have this professional knowledge, and it means that individual practitioners are using their professional judgment, which in itself isn't a bad thing at all. But we need robust data collection to provide objective, rapid learning from this praxis. And the risks from big data studies and not being routinely incorporated into assessments. And then finally, we're not looking at the relationship to long-term conditions. We know that long COVID is more common in people who've got existing long-term conditions, but we haven't explored that as well as we might. So what is the future research agenda? Well, for me, I think we're unlikely to progress our understanding of long COVID until we have more discrete, homogeneous subgroups. Identifying biomarkers for each of those would allow for better clinical trials by creating better controlled studies. There's a really urgent need for real-time pragmatic evidence of how to provide immediate relief to people. People with long COVID need to be real partners in identifying what the most urgent areas are, what are the symptoms that are causing them the most problem at the moment. We could approach this by collecting data through sentinel audits, and that could be used to develop complex intervention studies, the point that David made about the multiple anchors. But that means reviewing our approach to research funding, and that we'll have to embrace different research methodologies. So I'll be very interested to see what my colleagues on the panel have to say about the research landscape. Thank you.
Thank you so much, Dr. Maxwell. In the interest of time, let's move right to that panel. And instead of me going around the room and introducing, how about just a brief introduction before you begin? Who wants to start?
I'm going to be first, that's okay, because I have the privilege of chairing this discussion. So we're going to come to Professor Nisreen first, if that's okay.
Yeah, hi, Darren, thank you, and hi, everybody. Well, I mean, where do I start? Introducing myself. I'm a professor of public health at the University of Southampton, and I've got lived experience of long COVID. Just reflections on research. Elaine obviously went through kind of the big landscape, but I just want to reflect a bit on my observation on the research studies of long COVID over the past couple of years. And I think there are a couple of features I identify from them. So if you actually look at studies around prevalence of long COVID or other studies trying to characterize long COVID, one thing that kind of you get conflicting, very different results in some of these studies. And to me, it looks like the main thing that causes that is the way the questions are asked. How you assess it. It's the method of assessment. Many of these studies have no patient involvement, no people with lived experience involvement in how you design and how the study and how you ask the research question, the overall research question, but also the questions that you're asking participants in the studies as well. And that is really, really crucial, because otherwise, nothing useful comes out. Actually, something harmful. Some of these studies have generated there might be harmful repercussions because they didn't think through these questions very well, and that reflected on patient care and recognition. So superficial assessment, I would call it, really is some feature that we have to overcome in research studies. And the main step to do that is to involve people with lived experience, because they would know, what are the key questions to ask. So developing those, researchers developing those with people. And because long COVID is very complex, as many other chronic diseases, so this reflection can extend to other diseases. I think the other feature that I found is rigidity. I would call it a rigidity in the analysis and in the interpretation of studies. And let's not confuse what I'm calling rigidity with scientific rigor. Science learns and moves on, and we need to learn from the complexity of long COVID and learn how to do things better, not only than asking the questions, but actually how you design, how you analyze, and how you interpret the studies. So I'll stop there. I think these are a couple of reflections.
Thank you, Nisreen. So we need to better understand the complexity, which will have added benefits for elsewhere, but truly focusing on co-production and the greater and meaningful involvement of people living with long COVID in all study designs and responses. So on that note of a greater involvement of people with long COVID, Dr. Karen Matthews.
Hi, I'm Dr. Karen Matthews. I'm a trustee of Long COVID SOS in the UK. And I also work in clinical research infrastructure as a kind of my day job as well. So I totally agree with Nisreen and everything that's been said about co-production. It really needs to involve those who are living with lived experience. And what I haven't said, my introduction is I also have lived experience of long COVID. I'm still living with it. And that is really important because, as Nisreen said, it leads to a better design study. So we've been involved in the therapies in long COVID study, and it was recognised right at the beginning of that the tools for measuring the symptoms weren't up to rigour for a long-term condition. So a new symptom-based questionnaire was developed for the quality of life of long COVID sufferers, because the standard questionnaires wouldn't bring out that picture of that relapsing, remitting condition by taking a kind of snap point of one day. And you're sitting, if you've ever been on a research study, sitting there and thinking, well, I'm feeling all right today, but yesterday I was feeling absolutely awful. The other thing that I'd like to raise as well is that there seems to be a dissonance between the acute COVID and the post-COVID. And I think in looking at and separating these out a bit too much, we're not actually, that's part of the reason why we can't see the causation of long COVID. And there's a study going on in COVID treatments in the UK called the Panoramic Study. And they've recently increased their outcome measures to, does it prevent long COVID? And I think that would be an interesting to find out what the results of that are, because I'll be testing those antivirals and seeing if they prevent the numbers getting long COVID, because I don't think any of us will want any more in our cohort. And actually, it may also bring out answers to what are the characteristics of the people who are developing long COVID? What makes us develop long COVID and other people recover?
Thank you. And I'm sure that if anyone is familiar with the programming, they'll be pleased to know that it's actually a session later on today on the episodic nature of long COVID, just as you talked about in terms of that relapsing and remitting. And incredibly important points there about better understanding the longitudinal trajectory from acute to chronic, and maybe some of the better understandings of mechanisms. But clearly the central role of people living with long COVID, again, needs to be centred and prioritised. So jumping across to another part of Europe, Tuuli.
Thank you. So my name is Tuuli-Marjatta Latvala. I'm from Finland and I'm a physiotherapist. I have a master's degree in health sciences as physiotherapy as my major. And I've been living with long COVID for 2 years now. I think when we talk about long COVID research on treatments and rehabilitation, and especially on rehabilitation, I think we should look into specific rehabilitation methods on certain long COVID subgroups. Because due to the heterogeneity of long COVID patients and the very diverse symptom profile and the fluctuation of symptoms, rehabilitation needs to be very carefully and individually planned. And so we need to know what is safe for the patients, and we need the science to back it up. Otherwise, terrible things will happen. We have seen it with ME/CFS patients. So I think we should be assessing, for example, pacing method for long COVID patients who are afflicted by post-exertional malaise. and assessing non-pharmacological dysautonomia treatments for those long COVID patients who have POTS-like symptoms and dysautonomia. And because the same rehabilitation protocol cannot be guided to all long COVID patients. And also in regards to developing long COVID definitions, I think it would be beneficial to distinguish those long COVID patients who are suffering from post-exertional malaise from those patients who developed prolonged post-infectious symptoms without post-exertional malaise. So in long COVID studies, the participants need to be screened for post-exertional malaise, and we should be using standardized definition of PM, and we should assess post-exertional malaise by using standardized subjective and objective measures, and especially prioritize research design where PEM is assessed during and after an exertion. Because if the patient is afflicted by post-exertional malaise, it will significantly impact on the content of treatment and rehabilitation.
Thank you, Tuuli. Really important reflection of learning in different and additional directions, but also reflecting what David Petrino said earlier about the approaches to complex illness are different. We can't have a one-size-fits-all, and that's for across all types of healthcare, medicine, care, and rehabilitation. So thinking about this, why don't we jump across the pond to Dr. Janet Bettger?
Hi, everybody. I'm Janet Prvu. I'm a professor of health and rehabilitation sciences. And, just in reflecting on the speakers so far, some really great points already. And circling back to something we heard this morning, I want to call out, again, leveraging platforms like today to continue in the future so that we can discuss and harmonize measurement. David was talking about, measuring at different levels, and we really had a difficult time these last couple of years bringing evidence together because measures are different in different studies being selected by investigators, as Nisreen mentioned, not often including people with lived experience, and we having an ongoing platform to share what people are choosing, how they're choosing it, why, and being able to hopefully unite on measurement for similar studies so that we can bring that evidence together. The second point I wanted to make has been repeated several times around engaging people with lived experience. And I guess maybe thinking of an opportunity here is how we can also engage people with lived experience as our knowledge translators. I mean, really, there's an opportunity here for lifting all of you up to be communicators. Because this brings me to my next point that keeps me awake at night, is that we're going to find and continue to find interventions or measures and tests that work, and people won't use them. Providers won't believe them, organizations won't adopt them, policies won't support them. And we really need communication to be part of our planning, really deliberate planning. And I often think back to when we talk about what translation looks like, even if we find something that is 100% effective. If we at every level lose 50% adoption, it will only reach and actually benefit about 0.6% of the population. When you think about the opportunity lost at a policy level, at an organizational level, at a provider level, at the point of patient choice, and at the point of adherence and continued maintenance. And I worry about that because there is so much lost in the work that we do because of those levels. So really, as we talk about engaging people with lived experience and having more opportunities to bring everyone together to also influence policy, workplace policy, I think is going to be critical. How we're supporting people in schools and education, and of course, our health policies.
Janet, thank you. That was so concise and diverse at the same time, and identifying the value of measurement in the context of heterogeneity and complexity, and therefore the critical value of leveraging lived experience and how it cannot be a fluffy side. It needs to be in it all the time, co-production. People with lived experience should be front and center. And in terms of that, the communication hope we do have from this forum a large knowledge translation plan, and I hope you will all see it in practice. But Elaine, what are you thinking, having heard the panel?
So I think I agree with all points the panel have made, which is great. I think that one of the challenges we have around the research landscape is the different mindsets, the different paradigms that people have, because we need to translate the knowledge in terms of getting it out to people with lived experience and the general public and policymakers. But the people who hold the keys to this, some of the scientists and some of the medical profession, have a particular view of what constitutes good research. And I think the point Nisreen made about you can be rigid, or we want to get rid of rigidity, but we don't want to get rid of rigor. And actually finding that way of translating, my final points are is that we need to look at funding research differently, and we need to use different methodologies. And actually, there is something, I think, about explaining why in long-term conditions like this, you need a different approach to your evidence base.
Thank you, Elaine. So in the last 2 minutes of this session, then, we're going to come round our panel, and you've got 30 seconds each. How can we actually put into practice the breaking down of rigidity, and the elevation of rigor with a community-engaged approach? Nisreen.
Oops, difficult. Just be innovative, work with people with lived experience, and just embrace innovation, because whatever if we make progress with long COVID research, we are making progress with other chronic complex conditions research. It's not just the one issue, but it has to be. People, I think even the researchers who do that, they are a consequence. They can be shot down by kind of the traditional ways the scientific community works. So I think it's about really trying to say, maybe it's allyship, the people who are working on these innovative ways coming together and saying, we want change in how we approach this problem.
Well, Nisreen, we're all here connecting change. So Karen. Oh, you're on mute.
Fail. I'd say break down those barriers, as Elaine's slide right at the front there showed. There's so many symptoms in long COVID. We need researchers working together and getting out of their comfort zones and silos, and they managed to do that with the acute COVID. They need to carry that through. And quickly, another one is also looking outside of like long COVID into the other conditions, like David Petrina had at the end, that slide, and fatigue being a very common factor in a lot of these chronic diseases. They probably have the same or similar causations, and maybe if they pull together, more progress can be made.
Further opportunities, connect across borders, silos, create that change. Tuuli.
Well, I think we should be keeping in mind, and we should consider that long COVID is not a huge exception concept compared to other post-viral illnesses, and we should be investigating the similarities and differences in long COVID and other post-viral illnesses. And I think I can't highlight enough the importance of acknowledging the previous literature on post-viral illnesses and how it should be applied into long COVID research.
Thank you. And I can see Jimmy has come into the room. So Janet, you get the parting shot. Off you go.
Very briefly, to reiterate the value of being bringing this message forward continuously in as many different ways as we can, and lifting up the voices that need to be heard that are often being silenced or ignored. I think our opportunity here on communication and engagement is from conceptualization of an idea through repeated communication, marketing, whatever people want to call that, to be able to share these messages of what we learn, what fails, what doesn't work, and how we can bring that into every corner of every community. And it isn't just in journals. It's not just in scientific forums. It needs to be in magazines that are on store racks in a grocery store. Long COVID is as much a part of public health as COVID, and it's here, and we need to continue to bring it into everything we do.